Good afternoon. We'll call this oversight and legislative hearing to order. Before we begin, I want to remind those members who are connecting with us remotely to please mute your microphone. This will cut down on the static feedback in the hearing room. The committee will receive testimony today from 2 administration and 2 tribal witnesses on evaluating the response and mitigation to the COVID-19 pandemic in Native communities. The Indian Health Service witness will also provide testimony on S.3650, the coverage for the Urban Indian Public Health Providers Act. This bill will make a total of 8 bills. Bill will get us to a total of 8 bills in 2 weeks that we've taken testimony on in committee. And I certainly look forward to marking up these bills and moving them to the floor in the coming weeks. Today, tribal communities are experiencing some of the highest rates of infection for COVID-19 in the country. The Indian Health Service recently reported more than 19,000 positive cases in the 12 service areas. Data also shows that at least 5 Indian tribes, such as the White Mountain Apache, the Pueblo of Zia, the Pueblo of San Felipe, the Navajo Nation, and the Kiowa Pueblo, have had higher cases per capita, outpacing states like New York, New Jersey, Massachusetts, and some others. Additionally, the Center for Disease Control and Prevention states that American Indians and Alaska Natives are in a racial and ethnic minority group at an increased risk of contracting COVID-19 or experiencing severe illness, regardless of age. American Indian or Alaska Native persons have a hospitalization rate 5 times that of non-Hispanic white persons. Because of these high rates, Native communities have taken needed measures to limit exposure and protect their people, instituting curfews or shelter-in-place orders, opening drive-through testing locations, closing non-essential businesses, ceasing tourism, and other revenue-generating activities, and switching schools to virtual platforms to provide necessary education to students are examples of how tribes are taking action in limiting the spread of infection from reaching more into their communities. In my home state of North Dakota, the first reported case of COVID-19 was on March 11, 2020. I can say that all of the communities across the state have taken measures to protect their residents against the coronavirus. One of the larger reservations in my home state is the Mandan, Hidatsa, and Arikara Nation, and they have provided a live community impact dashboard that updates COVID-19 cases found on their lands. This community has experienced 42 confirmed cases, causing the tribe to take protective measures such as devising a policy that penalizes members for violating quarantine orders. We should take a moment to acknowledge those law enforcement, first responders, and medical personnel risking their health to protect and care for those affected by the pandemic. Thank you all for your tireless work that is helping so many. As the country knows, there is no vaccine to protect a person against this respiratory illness, but work will continue towards finding one. And Congress will continue to fulfill the trust and treaty obligations to Indians. Through various funding authorized by Congress so far, the Indian Health Services has allocated approximately $2.4 billion to address COVID-19 needs. Today's hearing will provide the committee with an understanding of what both the Indian Health Service and the Federal Emergency Management Agency is doing to mitigate and prevent more cases of COVID-19 appearing in Native communities. Specifically, I'm interested to learn what is working well and where improvements can be made by reaching more rural communities, especially the tribal communities who have less access to resources that may be available in urban areas. We're also interested in what lessons have been learned from both IHS and FEMA during this pandemic. The committee is committed to understanding how the interactions between the IHS and FEMA is being coordinated during the COVID-19 pandemic response. I'm also pleased to see Mr. Scott Davis, Executive Director of the North Dakota Commission on Indian Affairs, here today testifying on panel 2. Scott works tirelessly for the 5 Indian tribes in North Dakota and is a former All-American marathon runner at Haskell Indian School. He was also a he was also a great basketball player. I watched him play basketball. He was very good at that. Good athlete. And he's an outstanding commissioner for Indian Affairs in North Dakota. Moving on to the legislative agenda of today's hearing. On May 7th, 2020, Senators Tina Smith and James Langford introduced S.3650, the coverage for the Urban Indian Health Providers Act. Senators Udall, McSally, Harris, Feinstein, Sinema, Moran, Tester, and Warren are also have joined as co-sponsors. This bipartisan bill amends the Indian Healthcare Improvement Act to provide parity to the Indian health system, which is made up of the Indian Health Service, tribal health programs, and urban Indian organizations. S.3650 expands the Federal Tort Claims Act coverage to urban Indian organizations. More than 70% of American Indians and Alaska Natives live in urban areas throughout the country. Urban Indian organizations are able to provide culturally competent care to Natives living in these urban areas. Currently, urban Indian organizations are not offered protections that are already provided to the IHS and tribal health program employees. UIOs spend critical dollars on malpractice liability insurance for employees and volunteers rather than putting these resources towards health care. Before we hear from our witnesses, however, I want to turn to Vice Chairman Udall for his opening statement.